In the third section, now we will discuss about the different types of carcinoids. Appendiceal and small intestinal carcinoids, rectal, bronchial and gastric carcinoids, and carcinoids without the carcinoid syndromes. Appendiceal carcinoid. So appendiceal is the carcinoid that is present in the appendix, is appendiceal carcinoid. Usually in the tip of the appendix. 2 to 5% of gastrointestinal carcinoids are the appendiceal carcinoids. Less than 1 centimeter in diameter. Here you can see the appendix, that's big swollen, less than 1 centimeter diameter. 2 to 35% have metastasis. Appendiceal goblet cells, neuroendocrine tumors, they are rare. Mixed adeno-neuroendocrine carcinomas are present, malignant and a distinct entity. So about 2 to 35% of appendiceal carcinoids, they are metastasis is present in 2 to 35% of the cases, and they are mixed adeno-neuroendocrine carcinomas, malignant and distinct entity. Prognostic factor of appendiceal carcinoid is the basal location, invasion of mesoappendix, poor differentiation, advanced stage, older age, and positive resection margin. So these are some prognostic factors that tells what is the prognosis of the appendiceal carcinoid. Next is small intestine carcinoid. Frequently multiple, they are 9 to 18% occur in jejunum, 70 to 80% in ileum, 70% within 6 centimeter of ileocecal valve. So ileum is very commonly affected as a result of small intestine carcinoid, and 70% is within 6 centimeter of ileocecal valve. 40% are less than 1 centimeter, 32% are 1 to 2 centimeter, 29% are more than 2 centimeter. They are well differentiated, generally invasive. 1.2% being intramucosal, 27% being submucosal. 20% invade muscularis propria. So small intestine carcinoid mainly in the ileum within 6 centimeter of ileocecal valve, and they are well differentiated, invasive type, but they are well differentiated, and as far as they are well differentiated, prognosis is good. Clinical characteristics of carcinoid of small intestine, we have diarrhea, flushing, pain, asthma, wheezing, pellagra, carcinoid heart disease. Percentage at presentation and percentage during course of disease. So different percentages are mentioned here, but the symptoms and signs of the patient with the carcinoid, there is flushing is very common, flushed red face, diarrhea, pain, asthma, wheezing, and carcinoid heart disease. Male are affected more. Median age at presentation is 57 years, range is 25 to 79 years, and during the illness also. So males are more commonly affected. Tumor localization, foregut in 5 to 14% at presentation, foregut. Then we have midgut and hindgut. So midgut is most common site of presentation at the time of the tumor. 57 to 87% is midgut, and also during the course of the illness. So common features, we have flushing, diarrhea, pain, asthma, wheezing, carcinoid heart disease. Males are commonly affected, and the common site of involvement is the midgut, and also at the time of presentation and during the course of the disease. Next, small intestinal carcinoid metastasis in mean of 47 to 58%. Marked fibrotic reaction occurs, fibrosis occurs that cause shrinkage of the small intestine. Here you can see the picture. Intestinal obstruction is common. Tumor size is important variable. Small neuroendocrine tumors less than 1 centimeter, metastasis in 15 to 25% cases. Duodenal tumors less than 1 centimeter, they never metastasize. Duodenal tumors, 33% are more than 2 centimeter and they had metastasis. So only the tumor less than 1 centimeter in the duodenum, they do not metastasize, but usually they are more than 2 centimeter and they have the ability to metastasize. Prognostic factor, tumor extent, proliferative index by grading and staging. So that's important about small intestinal carcinoid. Important factor is tumor size. If it's less than the 1 centimeter or more than 2 centimeter, metastasis is common. Rectal carcinoid. 27% of gastrointestinal neuroendocrine tumors are rectal carcinoid. They are between 4 to 13 centimeter above the dentate line. Dentate line is the line that divides the upper 2/3 of the rectum from the lower 1/3. So that's the dentate line. So mostly it is between 4 to 13 centimeter above the dentate line. Characteristics, mainly small, mainly invade submucosa, 2.1% confined to mucosa, 10% in muscular layer, and 5% in adjacent structure it can go. So mainly it invades the submucosa, then sometimes to mucosa, and then 10% cases to muscularis layer. Risk factors are the tumor size, depth of invasion, presence of metastasis, differentiation, recent TNM classification, and the grading of the tumor. All these are the factors that can tell us what's the prognosis of the tumor, whether it can be treated or it cannot treated, how well differentiated it is, how deep it is, what is the classification, whether it is locally present or it is metastasized to the nodes or to distant areas. So all these are the important factors in the finding. Bronchial carcinoids. 25 to 33% of well-differentiated neuroendocrine tumors. 90% are poorly differentiated, associated with smoking because they are in the lungs. 4 categories. We have typical carcinoid KCC1, atypical carcinoid KC11, intermediate small cell neuroendocrine carcinoma, and small cell neuroendocrine carcinoma. So these are the four categories of the bronchial carcinoid: typical, atypical, and then depending on the cell types, intermediate small cell, and then small cell carcinomas. Classification gives us different prognosis. Another classification is whether it's benign or low-grade malignant, typical tumor, low-grade malignant, atypical, high-grade malignant, poorly differentiated carcinoma of small cell, poorly differentiated carcinoma of the large cell. So this is another classification that can be used, which tells us whether the tumor is low grade or typical, or low grade atypical tumor, or whether it's high grade. High grade can be further poorly differentiated carcinoma of small cell, poorly differentiated carcinoma of the large cell. So these are the another method of classification of neuroendocrine tumors. Gastric carcinoids, 1.3 to 2% of all carcinoids originate from ECL cells. Hypergastrocnemic states type 1 and 2 generally pursue a benign course. Type 3 is a sporadic, aggressive course without hypergastronemia. We said hypergastronemia is in type 1 and type 2. Now we are talking about type 3, which has no hypergastronemia. 54 to 66% shows metastasis, single and large. 50% have atypical histology, can be a cause of carcinoid syndrome. So gastric carcinoid, we have type 1, 2, 3. 1 and 2 are hypergastronemic states, and then type 3, they are without hypergastronemic. 54 to 66% of these can metastasize. They are single and large. You can see single and large can cause carcinoid syndrome. GI lung carcinoid without carcinoid syndrome. Diverse pre-sensation related to site of origin and metastasis found during surgery. And these are the neuroendocrine tumors in jejunum, silent. They are silent, they do not produce any symptoms, do not produce carcinoid syndrome, and during the surgery they are diagnosed during some other surgery. So they are found during surgery. Periodic abdominal pain, 51%. Intestinal obstruction in 31%. Abdominal tumor, gastrointestinal bleeding, delayed diagnosis. There is duodenal, gastric, rectal endoscopy is used for the diagnosis. If symptoms are not produced, if they are not associated with the features of carcinoid syndrome, the diagnosis is usually delayed and they are found on the surgery. Clinical symptoms are the rectal carcinoid. We have melena bleeding, 39%. If the rectal carcinoid is present, bleeding per rectum or melena bleeding in the stools is common. Constipation is present. Diarrhea. If it's bronchial, lesion on chest radiograph is visible, 31% are asymptomatic. Thymic anterior mediastinum mass is present. Ovarian and testicular masses discovered on physical examination. Liver, hepatomegaly, and the normal LFTs. This chart is very good presentation of different symptoms associated with the carcinoid of different organs or neuroendocrine tumors of different structures, including rectal, bronchial, thymus, ovarian, testicular, and liver. Gastrointestinal carcinoid with systemic symptoms are the ones which have numeral gastrointestinal peptides like gastrin, insulin, somatostatin, motilin, neurotensin, techikinins, substance K, P, glucagon, gastrin-releasing peptide, vasoactive intestinal peptide, ghrelin, ACTH, calcitonin, growth hormone, prostaglandins, and bioactive amines like serotonin. So these are the peptides produced by the gastrointestinal tumors, neuroendocrine tumors, and they are responsible for producing different systemic symptoms associated with gastrointestinal carcinoids. Peptides may or may not be released. Elevated serum of polypeptides in 43% of cases, motilin 14%, gastrin 15%, VIP in 6%. Foregut neuroendocrine tumors, they are more likely to produce peptides. Clinical features are the Cushing syndrome, ectopic ACTH syndrome, acromegaly, somatostatinoma syndrome, and carcinoid syndromes. These are all the syndromes associated with the production of different peptides associated with gastrointestinal tumors, and then they produce different systemic symptoms and the syndromes. So that was all about this section. Thank you for watching sqadia.com.